Good morning, everyone. My name is Dr. Matt Goebel. I am the Assistant EMS Medical Director over at Mercy. Most of you probably know me from being at Bay State the last 5 years for residency and fellowship. So I'm talking about some updates in terms of pre-hospital cardiac arrest management today. I have no financial disclosures, but if you have any to offer, I'm a cheap date. So the subtitle or the alternate title for this talk would be what I thought I knew about cardiac arrest. And so there's 3 areas I'm going to cover based off of recent literature, and that has to do with compression ratios, end tidal, and epi. So the first question is a matter of compression ratios. Now, what I thought I knew about compression ratios was that pressure drops during CPR pauses. It takes time to get that pressure back when you resume CPR. Therefore, more compressions is always better. So in general, when faced with the choice of doing 30-2 versus continuous CPR, I and most providers that I know have chosen to do continuous CPR, and even if we don't have an advanced airway in place. Now, despite the AHA teaching guidance being you do 30-2 until you have an advanced airway and then you do continuous compressions. This is such a common thought process that it's even made it into the state protocols where it says, funny enough, follow AHA/ILCOR recommendations, which number 1, don't always agree with each other, those 2 organizations. And then number 2 immediately goes on to contradict AHA guidelines and say, do continuous CPR and try to bag during chest recoil. You know, welcome to Massachusetts. So, in this study, they looked at the ROC continuous compression study, and then they looked at just the patients that got 30-2 CPR, and then they looked at the thoracic impedance data during CPR to try and understand who got good ventilation and who got bad ventilation during the CPR pauses. Now, I was rather shocked. I'm very grateful that Amir was just talking about the 10% like survival, so we all have a kind of baseline where we're looking at these numbers for the rest of the talk. So the neurointact survival in the 30-2 with good ventilation was 10.6%, and versus 30-2 with bad ventilation was 2.4%. So like a dramatic, like 4-fold difference in doing good bagging versus bad bagging. Now, I've added the data from the original study, from the continuous arm, because these data are all taken from the same study, so I think it's a valid comparison, since this was just a subgroup analysis. But you can see that the neurointact survival in the continuous CPR arm from the original study was 7%. Now, the outcome in the original study looking at continuous versus 30-2 was that there was no difference, and that's probably because all of the 30-2 people were lumped together, good and bad ventilation. But 30-2 with good ventilation probably is better than continuous. But I do want to emphasize that the study comparison here was 30-2 good versus bad ventilation. They didn't actually compare to the continuous arm from the original study. So now what do I do? Well, the number 1 problem is, well, okay, so what is good ventilation? And how do we measure that? How do we do that? They were using thoracic impedance, which is a surrogate measure for tidal volume. There are devices for measuring tidal volume and making sure you're giving good breaths, but they're certainly not widely available and they're quite expensive. So it's not going to be easy to determine what is good versus bad ventilation and how do we apply that prospectively. And furthermore, if you're on an EMS crew and the state protocol says do continuous CPR, if you do 30-2, is that considered a protocol violation? So I polled a bunch of other medical directors and the general consensus was maybe, I guess, kind of, maybe technically, not one that I care about, not one that I'm going to report. So I'm not sure exactly what to do with this. My instinct is that I want to do good 30-2. And that's my interpretation of the data, is that's probably the best thing for the patient. And if you want to do 30-2, you're probably backed up by the fact that the protocol says to follow AHA, even though the protocol then goes on to contradict AHA. So Secondly, end tidal. Now, what I thought I knew about end tidal was that low end tidal bad, high end tidal good. Okay, pretty straightforward. Very, very simplistic, good model for my ER doctor brain. So, hypothetical scenario. You have a witness cardiac arrest, initial rhythm was VFib, but now it's been PEA systole for the last, we'll say 45 minutes. Okay, you're going on an hour plus of CPR right now, but the end tidal is 70. Who wants to keep going? Who wants to stop? Okay, everyone else is abstaining because you don't want to vote. I get it, okay? Right, because it's a bad situation. You don't know what to do with that, right? You're like, oh man, but the end tidal's still high. I don't know what to do with that, right? So in this study, they were looking at pre-hospital end tidal CO2 and the cardiac arrest outcomes. And what they found was quite interesting. So these are the unadjusted outcomes looking at total end tidal, pre-ROSC, post-ROSC. And what you can see is a general trend of low end tidal bad, normal to high normal end tidal good, high end tidal also bad, okay? Now when they adjusted this for all of the factors that you would think of normally, age, witness, bystander CPR, shock rhythm, et cetera, they came up with these graphs. Now, the one that when everyone talks about the study they're trying to look at is before you get ROSC, if you're looking at the end tidal, how does that affect the odds for mortality? And unfortunately, all of the odds ratios cross 1, so they're not actually like significantly predictive. But the graph that I find most interesting is the post-ROSC one, where there is a very strong correlation between low and high end tidal being increased with worse mortality. So I think maybe the takeaway from this study, now the question is, okay, so you have abnormal end tidal post-ROSC. Is that a marker of something bad physiologically going on, or is it a marker of bad ventilation, right? So we don't know. So my takeaway from the study is that low end tidal, bad, normal high probably is good, high end tidal probably also bad. Whether that is the smoke or the fire, I don't know, but I'm gonna try and correct it to the normal or high normal range through my use of ventilation. Okay, last study, epinephrine. So what on earth could be new about epi and cardiac arrest, right? Like, it's been studied up and down. One of my favorite hobbies is dunking on using epi and cardiac arrest, arguing with people on Reddit and Twitter about it. But like, what could possibly be new about epi? So things that I thought I knew about epi was that a rock can get a pulse if you give enough epi, and that it doesn't increase neurointact survival, right? You get ROSC, but you don't get like a walking, talking normal person afterward, right? You are creating long-term care patients, you're not creating neurointact survivors. Now, to these assumptions, the Salt Lake City Fire Department said, hold my Diet Coke. Now, in this study, they looked at standard ACLS versus standard ACLS plus early administration of IM epinephrine in cardiac arrest. Now, they only did this with their ALS units to isolate the effect of giving the earlier IM epi. And why 5 milligrams, you ask? Well, the concentration of epi that was available is 1 mg per mil. The highest volume you can give is in the thigh is 5 mils, thus 5 milligrams. There is also some physiologic pharmacokinetic data to suggest that 5 IM is roughly equal to 0.5 IV. So, probably administration of earlier and maybe slightly lower dose epinephrine. And here's what they found. Now, when you look at these numbers, we need to keep in mind that they excluded all of the one-shock wonders. So everyone that got ROSC after like one shock or whatever, they're not in this data set, okay? So this is people that continued to be in cardiac arrest. Because if you got ROSC on the first shock, it wasn't because we gave you epi 30 seconds ago, okay? Now, in the IVIO only arm, neurointact survival 6.2%. In the arm that also got IM epi, it was almost 10%. Now, that's an absolute difference of 3.65%, which would give you a number needed to treat of 25 for neurointact survival, okay? So this is a cardiology conference, so I'll frame this in context of another cardiology intervention. Aspirin for STEMI to improve mortality. What's the number needed to treat? Guesses. Who says 20? 30? 40? 50? Stop asking, I'm not gonna vote. Okay, got it, received. So the number needed to treat to save a life for a patient having a STEMI is 42, versus here, epi for neurointact survival is 25. So this is potentially even more powerful than giving aspirin to a STEMI patient for saving lives. Now, granted, these smaller studies, they have larger confidence intervals. They, as a generalization, tend to overestimate the efficacy. But even if 25 is an overestimation, this is still potentially a very powerful intervention. Now, why does it work? It may come down to timing. So in the Paramedic 2 trial, which I know and love for dunking on giving epi and cardiac arrest, the time from initial arrest to first dose of epi was average of 21 minutes. Now, part of that is probably driven by the fact that the protocol was IV attempt, then go to IO, whereas in the modern era, we tend to go IO first. So in the standard ACLS arm in the Salt Lake study, their time to epi administration was 15 minutes. And in the IM arm, it was 12 minutes. So perhaps part of the messaging with epi is that we just must go faster. Now, I think this also raises some important questions about how this intervention is delivered. Now, remember that I said it was only their ALS providers that were doing this. So what happens now when we have a 5 milligram EpiPen that we can put on that BLS engine that gets to the cardiac arrest faster, right? Because they're already trained how to use it. Just got to make sure you give the cardiac arrest epi, not the anaphylaxis epi. That wouldn't go poorly. Or the other way around. Now, alternatively, we've also had great success with putting AEDs and Narcan with law enforcement. So can we create a tactical enough EpiPen that law enforcement can carry it and put it with their AED and they can administer that up front? Or even alternatively, recently the FDA approved intranasal epi for anaphylaxis. So are we gonna find a nasal dose of epinephrine that'll work for cardiac arrest? And then, people are already learning how to administer Narcan. Can they administer nasal epinephrine for cardiac arrest as well? I don't know, but this is a very interesting future for this intervention that I thought we'd already studied up, down, and sideways. So the things I thought I knew about cardiac arrest that I now think differently about, 30-2 with good ventilation is probably better than just continuous CPR. Low end tidal, bad. High end tidal, also bad. And that early epi, by whatever route, most recently studied as IM, holds promise for becoming an intervention that will save lives. That is all I have. The QR code goes to a PDF of my slides if you want to look at anything, including the references and whatnot. Thank you for your time.